So thank you all for joining. My name is Caroline Knutson. I am the COO and one of the co-founders of the After Cancer. So the After Cancer is a digital platform for cancer survivorship support, and we partner with hospital systems,
Yeah.
nonprofits, other organizations to be an extension of survivorship support. And what we're really passionate about is bringing key topics on survivorship sort of to the conversation and connecting with others in the survivorship ecosystem. And so that's the point of this session. So we do these once monthly. These are called expert insight sessions. Each one has a specific topic, and we bring two wonderful experts, sometimes three, to the room to offer different perspectives on that topic. And so today we are joined by two brilliant experts who I'm thrilled to introduce you to. So we'll get started. Marci, would you introduce yourself?
Hi, I'm Marci Nilsen, and I'm a nurse by training. I'm a PhD scientist. I'm focusing mainly on symptoms and kind of biobehavioral research. I'm a professor in the Department of Otology at the University of Pittsburgh School of Medicine. I direct a multidisciplinary head and neck cancer survivorship clinic, which I'll highlight it probably throughout this talk. And I'm also the co-leader for Cancer Risk Outcomes and Prevention, or CROP, which is our program at the UPMC Hillman Cancer Center.
And Amelito.
Hello, everyone. I'm Amelito. I'm a physician by profession. I'm now a postdoc fellow at Northwestern University up here in Chicago. With a focus on disability and employment. I'm also head and neck cancer survivor myself, and I'm excited to connect with y'all and to share our mistakes both as a physician.
Great. Thank you so much. Welcome, both of you, to this chat. So today we will be talking about head and neck cancer and survivorship. For those of you who are in the call, please feel free to drop questions or comments into the chat as we go, and we'll weave those into the conversation or save them for the end, depending on how we go. But to kind of get us started, I'd love both Marci and Amelito for you guys to kind of reflect on survivorship as it pertains to head and neck cancer. So what does that really look like in practice? What does active treatment ending and that transition into survivorship look like? And why is that unique in head and neck cancers?
I can go first. So I will make the argument that survivorship, at least in head and neck cancer, is better served earlier than later. And I think that goes with the definition. And I know many people, you probably hear this a lot, many people don't really, or survivors don't always feel um, or like the term survivorship, but I do think it kind of helps us at least have a common term that we can use. So for me, survivorship in head and neck is really complex, just based on the fact that most of our patients will get more than one treatment, so surgery, chemoradiation, or even just chemoradiation together. And so it's the complexity of the treatment, but also the fact that there are so many structures in a very small area, that the treatment then affects. And it's very kind of um, easy to focus on some of the ones we think about, like swallowing and speech. But I think with the research that's gone on over the last 10 to 15 years, we're really seeing a lot more um, treatment effects that maybe have not been highlighted, but are prevalent in the group. And that after treatment, the journey can look very different over time. And so survivorship is not always kind of just a one glance. It really can ebb and flow over the years during to after treatment. So it makes it complex for providers. It makes it complex for patients and survivors and caregivers, to kind of really address all of the needs that they have.
And I can add to that on too. So I agree that it's always better for us to start early uh, in building survivorship and management. But I think one of the challenges are that I've seen is that sometimes it's not very clear on how providers define survivorship. It's like, when are you even considered a survivor? And this why I understand, I think that's where it's coming from, that some providers or even patients or individuals who don't like the term survivorship because there's a sometimes undefined uh perception on it. It's like, do we have to wait 1 year or 2 years or 5 years after treatment before we even call ourselves that? But I do believe that after you finish treatment, there's already different phases on your journey that you will have different needs. Like, for example, in the first year, maybe you will deal with side effects from treatment. Maybe in the second and third years, you're trying to improve your um, rehabilitation, speech and swallowing. And as you go into 4 or 5 years, you'll probably like roll into the after late effects of treatment, and then you want to progress over your jobs or your careers. So I think you should really start from day one, right after treatment, and just um, deal with the specific needs at your specific phase, but then also plan ahead for the future of your like um of the survivorship phase.
And I think you really highlighted some of those key issues that actually, Marci, I wanted to ask you about how to address them. So those things about speech, swallowing, body image, nutrition, these are a lot of complex needs. And that sort of phased approach you were talking about, Amelito, I'm curious, Marci, in your practice, how is care typically structured to meet those unique needs, sort of the way it is now? And where do you see it sort of breaking down in the real world practice?
Yeah, so I think one of the things that we highlight here is that survivorship too is not just the physical. So you mentioned some other, like the body image, the psychosocial effect, and so, but when we do it in our practice, and part of it was initiated really by our other providers, so our medical and radiation oncologists, but we see patients before radiation. A lot of times before surgery, it's really hard. We do some things to optimize before surgery, but this allows us to pair patients with providers to follow them through treatment and then kind of reassess after treatment. So the big ones that we address in clinic, we have a speech language pathologist, so swallowing, understanding a baseline swallow. If you've had surgery, that could have already changed you, or the cancer could impair your swallowing a little bit. So trying to, start you off swallowing safely and effectively, giving you those kind of exercises, those prophylactic exercises to take through. Dietitian, physical therapy, dental, making sure you have dental clearance, making sure you have a good dental cleaning, just trying to get your teeth, the patient's teeth in shape as much as possible. And I'm sure I'm forgetting the nurses, speech language pathologists, physical therapists, dentist, dietitian, are the group we kind of start with. And I know that there could be more. So I'm a certified hospice and palliative care nurse. So we do screen for anxiety and depression because we know that's prevalent in our group in head and neck survivors. So we do also do that through screening and then care coordination. And so why do we do that? We've kind of looked at it in terms of a kind of with the goal of learning. Does this approach make a difference for patients? And when we looked at this model, seeing them early before radiation, they had better function at a year. And I know before the call came out, we have a paper that we presented at the American Head and Neck Society this summer that is hopefully to be in publication soon. But we also saw that if you had a pre-radiation visit with us in a multidisciplinary clinic, you were more likely to adhere to treatment, so complete radiation on time. And then when you control for that, our patients actually, pre-treatment visits were associated with improved survival and decreased recurrence. So I know that not everyone has the ability to have all these providers. And so I do recognize that we're lucky to have such an in-depth clinic. But I think part of it is really just establishing those pathways for patients and making those connections as a provider so that you can send patients to a speech language pathologist or a dietitian or someone that has familiarity with head and neck. And even online resources, education, all of those things. I think the earlier allows you to build that relationship, start having those conversations. And then even if patients aren't ready before radiation, at least they have someone they can ask and someone they can reach out to. And then we can circle back after treatment and see where they are. And so we do repeated visits. We're not a one and done. And I think that's part is the relationship we build, seeing people pre-treatment, post-treatment, and then annually within the surveillance kind of grouping.
And I think, that's something we've definitely struggled with, right? I think in survivorship, sometimes it feels like when someone is going into treatment, they're very much in that survival mode, right? Of just getting through the protocols. And it's hard to think about all of those other things you mentioned. Would love to hear a little bit more about how you make sure that people are equipped and empowered before and then get that follow-up afterwards when maybe they're ready to actually do something about it. So just curious, you did kind of mention that there were those touch points, but would like to know a little bit
Yeah.
more about that.
Yes, so we do try to, we provide materials for patients before. So in addition to having these conversations, we do a treatment summary. I know they're not really care plan treatment summary. They're not mandated anymore. But what we found was helpful is that each of the providers would leave a patient-facing note. So a real quick recap of what they talked about with contact and information. And then for most patients, they'll either have a dietitian or a speech language pathologist follow them like every other week during um, treatment. So it's kind of hard to forget about them. But then it's always hard to talk about things that you've never experienced before. And so as they start to go through radiation, they do start to, feel that sensation of more thick mucus. And so then they want to know what to do about it, and they'll have people to answer. And we always match, the providers if they're going through radiation. We use the radiation oncology, kind of approve what they use, so it matches what they provide. But as those symptoms start to creep up, you know who to talk to. And so that's been one of the comments that our survivors have mentioned is that they feel kind of seen and heard because they know who to contact and who to discuss these changes with. Are they to be not normal? Because normal is like, this, but are they to be expected? Or is it something out of the ordinary and they need to seek a little bit more help?
And kind of back to those kind of common issues for those of us who might not do a lot in head and neck, and I'm not sure who's on the call, so if folks are experts, you probably already know, but for those of us who might be more generalists, what are some of those common issues that patients sort of arrive to later that would be better addressed earlier on so that they can have a little bit more signposting?
Yeah, so I think swallowing dysphagia is one of the big ones, but most of my research and my work is related to the musculoskeletal changes that patients have, especially in the neck, the shoulders. Lymphedema goes with that, so radiation fibrosis. We always think about, I think it's very easy to think about radiation as being done when it's done, and we kind of talk about the acute effects of it. But it's easy to not think about what happens 9 to 10 years down the line. And I just had a survivor come back to our clinic 9 years down. And she was like, I didn't know why I had to talk to all these people 9 years ago. And she's like, but now I really didn't think I could have used them along the way because she's more neck stiffness, more trismus, and difficulty opening your mouth. So we've shown in some of our early work and this is not going to be surprising to most providers out there. So if you're a physical therapist, earlier PT, you're going to improve function. So it seems very intuitive, but it doesn't always happen and is not always recognized. And so that would be the two big ones that I would pick out. Um, as a survivor, you can add to them too. And I think let us know other ones. But those are the big ones, I think, by numbers and by um, what we've been able to show in data.
Brilliant. And last question for you. So you mentioned a little bit at the top in your intro about the work that you're doing with the UPMC in terms of
Mhm.
cancer risk, outcomes, and preventions. Would love to know sort of how that's informed your practice when it comes to survivorship for head and neck cancers.
Yeah, so I think one of the things that we know is HPV. So HPV is increasing in the prevalence in head and neck cancer. And so part of what we also do during that work is kind of facilitate, vaccine uptake. But I think it's also helped see where the gaps are for our community. So in UPMC, we have an NCI designated center, but we serve most of Western Pennsylvania and in New York, Ohio, Maryland, and West Virginia. And so having those other, even if they're not head and neck specific researchers, having all of that group of experience looking at different cancers and looking at gaps and barriers all really feeds into what you can do as a researcher in your area and kind of leveraging some of those strengths. Some of my work with one of my epidemiologists who's also in the program has allowed us to see really who we're serving and who we're not. And distance to center is a big one. It's not as big as it is bigger than insurance, so really just that distance. And so, how can we start to expand our program to reach those patients since we know they're less likely to, come be able to. And I never want to say they don't want to, but I'd be able to because there's a lot of things that go into, traveling to Pittsburgh from Erie or Central PA. How can we start to get some of this high quality care to them in a way that's feasible? Because I personally don't believe that high quality care should be really only available to people in certain geographic areas. We really need to be able to provide that type of care regardless of where people live.
Where they are. And I think that's a nice segue, sort of thinking about sitting with people's kind of experience to transition into understanding a little bit more about your experience, Amelito. So I'd love for you to share, sort of as a survivor, kind of what did you expect it to look like? What did that journey look like in terms of diagnosis into treatment and into transitioning into care? And what was sort of surprised you for the better? And then what were sort of some gaps or things that really turned out for the worse in that experience?
Yeah, I think that's an excellent question, and that I think my experience really highlights the multifaceted nature of head and neck cancer, the condition itself, and the survivorship phase. That makes it, I would say, special, unique, but then very challenging at the same time, and that's why it also requires a lot of interprofessional collaboration as well. I'm um, blessed to be able to go to a comprehensive cancer center at MD Anderson in Houston. So I kind of have the front seat into how a cancer center should ideally be. But obviously, we know for a fact that that might not be possible in all parts of the country or maybe even the world. But what I would say is that one way that we could um, mitigate that is to highlight the role of PCPs, of your primary care physicians. I know some MPs do it now as well, some PAs, but if you're in a place that don't have the resources of a comprehensive cancer center, I think that the coordination and the main coordination of care that's run by PCPs would really become so important. That might mean that there's a lot more for them, but sometimes we have to step up if ever our patients are not in an urban setting, cancer center. But to go back to the question about my own survivorship, pretty much the same. All the side effects that we've been discussing about, I had, um, yeah, like lymphedema, trismus, obviously speech impairments and swallowing difficulties as well. But I want to add to that um, because it will start with swallowing impairments, but then depending on the level the baseline level of the patient, if they're a bit older, but a bit more bedbound, it might put them at a higher risk for more serious complications like aspiration pneumonia. And that's definitely one of the complications that we should avoid at all costs. But other than that, I think for younger folks, issues about employment, about relationships, about self-image are definitely one of the highest, I think, priorities for us.
Yeah, and sometimes those are the overlooked things, right? Is so we're so focused on the physical that we forget about all of those things. And as you mentioned, also for younger folks who have a very different environment as well, where they're navigating work and school and friendships and changing relationships, and that's a whole other element that's just as true for head and neck as well as other cancers as well. So you are also Dr. Amelito, which means you bring kind of a clinical lens. Do you feel like that impacted your experience for the better, for the worse, in terms of how you kind of approached all of this?
I would say yes and no. I think I've, I'm in a unique position, like, of being a doctor and a survivor myself. I haven't met anyone who had this specific type of cancer, who's also practicing medicine as well. So definitely, I mean, I'm on my own. Like, apart from my own doctors, my own therapists, like, I haven't navigated this myself. I met some with different types of cancers, maybe colon or leukemia, lymphoma, but I think head and neck's still a bit different just because it affects a lot of your basic functions, right? In the area of your anatomy right here. I would say being a doctor is really helpful because I kind of like know what to watch out for, what to look out for, and what questions to ask to my doctors. But at the same time, it's also a bit difficult because it's hard to sometimes overthink, like, oh, this might be something more, this might be, like, and it's hard to do that. I mean, it's hard to do it in your own patients, but it's even harder to do it if you're talking about yourself. But what I've found over the years is that um, I can use this platform to become a voice to other patients who do not necessarily have the same um, platform that I have or voice that I have. I'm very fortunate to have a very good type of recovery, type of survivorship, and I just want to use this chance that I have to advocate and to um, speak up for those who might need it more than me, and that's partly why I'm here today as well.
Well, we're thrilled. And I think you mentioned two really important things there. There's like that are the two sides of the coin. And I think it's something we all wish all of our patients knew more so that they could self-advocate, they could watch the signs, they could be paying attention to those really important elements of surveillance. But there's that other side where you don't want to create fear. And it's something that we on our platform in terms of our content have been really mindful about is how do you strike a balance of creating enough awareness and empowerment that people have the information they need, that they can take care of themselves, but without creating this like constant feeling like you're hyper vigilant and this, increasing of the fear of recurrence and what do these mean? And every pain might mean something. So I'm sure you on an exponential level are in those two spaces. So great that you share your stories. And thank you so much for being here today. And I think it's really important for people to hear their story in the mouths of others. And I think the more that you're able to do that, it's such a beautiful gift to other people who are going through it as well. So one last question for you is now that you're sort of on the research and clinical side, has that sort of informed a way that you would like to redesign care systems in general? So having now you've had to go through this as a patient, you're also researching. Has it changed the way you would want to structure care in general?
Yes, yes. So when I was having my treatment and many of my medical appointments, I've had like the front row seat of how the system works, and it's kind of hard. Like, I was trying to focus like on my treatment alone, like as a patient. Sometimes I can help it. Just because I know a bit about the healthcare system, it's like I've identified some of the areas that could improve. And I think one of them is just basically how um different specialties or different interprofessional communication. It's like who refers to where or when. I think it create some point of confusion for patients. Like for me, I was confused at some point. It's because they were transitioning me over to a survivorship clinic, but then MD Anderson has different types of survivorship, like general survivorship and head and neck cancer survivorship. So if I'm was confused, I want more for lay individuals. So I think communication, it might sound basic as it is, but I think it's just very important to emphasize to the patients, like if they need something, who should they reach out to and where should they go to for their appointments? Something basic like that might really help. I think another point of that, or another um challenge that comes out of that is the referral system. It gets very complicated depending on the type of insurance a patient has. It's like if they need an ultrasound, for example, they would have to get they think they would have to get a referral from their primary care provider to a specialist, and the specialist will order the the test that they need, and it will take months, if not years, for them to get a fairly simple test. I'm still not sure how to address that, but I think it's a problem that's embedded into the system itself. But for our part, I think being informed, like reading the fine print of, for example, insurance policies might help, and helping explain that to the patients in a manner that they should understand will, I think, will then it will go a mile, right? It will help them really very much.
Yeah, absolutely. And I think that's something that everyone on the call can relate to, right? Is how complicated that whole process can feel, and it's an extra burden on people who are already going through such a difficult moment to then have to navigate those intricacies and read the fine print that sometimes we all don't read. So this is kind of, I'd love to hear both of your perspectives on each of these questions. And this will be a little bit related to the last one you just answered. But for both of you, what do you feel is the gap in survivorship support that patients feel most acutely now, that doesn't show up clearly in clinical guidelines or in quality metrics? So when it comes to sort of what does good look like, is one that's not really in a guideline and isn't really easy to measure. So not sure if you guys have thoughts on that. Maybe we'll start, Marci, what you might think based on your experience.
Ooh. I think it's really a relationship. I think, and I think it's really hard to measure that, but I think survivorship really works well when you can build that relationship with a patient and you see them over time. Um, so I don't know how you measure a relationship. Um, but I would also again say, a lot of the clinical guidelines that we have, like the Commission on Cancer, a lot of those require survivorship services post-treatment. And I just really firmly believe that this is at least a conversation and potentially some of the resources that need to happen early. Um, and I think a lot of the things that end up getting done are care coordination, identification that are very easy to kind of miss. We're very thankful when they happen well, navigation, care coordination, social work, but they're really easy to kind of gleam over. But when they don't work, it's evident. And there are some measures, with the physician fee schedule to try to get principal illness navigation more integrated into care. And that comes with its own challenges because they come with copays. And I think we've highlighted it a little bit, but cancer can be very financially burdensome for patients. And so then being able to get them good care shouldn't have to become at the cost of additional copays. So those are the things that I think are important. I think they're hard to measure, they're hard to see. Um, but when they work well, I think everyone knows what that looks like and can
You can
feel
feel
it.
it.
Yeah.
Brilliant. I think those are great ones. Amelita, what would you add to that in terms of your experience?
So I think right now we're in very interesting times, with the advent of AI and chatbots. I'm a member myself of a patient support group for head and neck cancer survivors who are mostly young adults. And on a daily basis, I get the chance to see their posts and the questions that they're asking. And unfortunately, there's a lot of them that we might think it's basic information, but they are misinformed, unfortunately. And since for providers, and I do my best to, answer as well, but I also don't want to like be the know-all like type of person. But I think it just highlights the fact that as providers, we have to be able to keep up on how our patients use AI and the internet to seek information about their health. I know that's difficult, but as providers too, we sometimes use AI as well. But I think that's a responsible way to use it. And because sometimes patients will come to your appointments already, they have an idea of what you're going to tell them. They have on the phones, they have a screenshot of what ChatGPT might have told them. So I think that would demand a bit more effort and time for us to carefully explain to them whether that's right or wrong. But yeah, I think in these times we have to be able to like keep up and make sure that AI won't replace us. I know it wouldn't, um, but yeah, definitely a challenge that is more modern and haven't seen before. So it's definitely an emerging concept for us. But I'm never part of it. Um, I think it will also be helpful if we as providers will, and it's difficult to speak because sometimes I speak as a survivor and a physician, but as a physician, it might be helpful if we ask patients questions about topics that they might be embarrassed about. Like for example, for young adults, um, they might be shy about raising topics about intimacy, about mental health, and my thought is that if the questions come from us as providers, it might make them more comfortable to open up a bit more. Yeah.
I think that's a great idea to kind of normalize it, right? I think a lot of people sort of sit with it and they marinate in these questions and don't know who to ask, and they're often going to ChatGPT, right, to answer them. And I thought that was a really good point too about patients coming in with the printout. I think this is the first time we've been seeing it, even I think just this year, of people who are doing a lot of research. And on the one hand, it's great because information is power. And on the other hand, it's can we trust this information? You risk the self-diagnosis. So I imagine as a clinician, that's a really difficult sort of line too, and something, yeah, that's a gap that needs to be addressed. So we've got a mixed group, I think, in the audience today. So some who are experts and some who are not. And so I think just in general, I'd love to know from both of you, for those who maybe are not, what's one thing that anyone could do who's in the space of treating and caring for cancer survivors that they could do to meaningfully improve survivor experience when it comes to head and neck cancers?
So I'm going to tag on, I think, to your answer that you just gave, Amelito. I think as providers, we see a lot of survivors, so we kind of know the common things that occur with patients. And again, it's like one of my survivors says, I didn't know what I didn't know. And so how do I know what to ask about. And so that is kind of what we really, one of the things we bring to the table. And so instead of going in and saying, like, how are you doing? Working in those most common side effects into your conversation. I saw you last year. You mentioned you were able to eat this and this and this. Have you noticed anything different, anything harder to eat this year? Are you coughing more? Are you getting more tightness in your neck? All of those things, if you're really aware of the most common things, you can help patients connect them to their diagnosis because sometimes it could be 3 or 4 or 5 years out. I had a patient that was like, my neck really hurts. I've gone through 7 pillows. And I'm like, I hate to tell you this. It's not your pillow. Let's talk about it. Physical therapy. And so framing and bringing up topics that, may not be not uncomfortable. These might be easy topics, but the topics that they just don't know are related, but also bringing in some of the other ones, like, how's your mood been? You know, do you have good days, bad days? Are you more anxious? How's work going with, not being able to lift your arm? So really being able to help kind of help them navigate those and bring up questions, help them kind of find and identify questions that they can bring up instead of, how are you doing? They're probably going to say, I'm doing okay, I'm doing fine. Um, Especially if it's an oncologist, they don't want to be like, yeah, they're very thankful for all the care that you've provided. And they may not want to be seen as complaining. And I always say it's not complaining. If there's something we could do to make your life a little bit better, I'm in for it. Like if it's just a twinge in your neck and we can fix it, then let's try to work on it. Or if it's something bigger. And so that would be my one thing. I would say I probably could have 10 more things, but that would be my one thing.
I love that one because I think the more sort of up in our user base, that's the number one thing I see is people sort of think cancer is tough. And so
Hmm.
all of this is tough. And there's almost like you need to give them permission to, you don't need to suffer with this stuff.
Hmm.
That isn't necessarily normal. I know we don't use that word, but you give them, I think those questions are such a safe way to give permission
Hmm.
to people to reflect on
Hmm.
and then feel met in the middle. So I think that's a brilliant suggestion we could all implement.
I wrote it on the back of my card that I gave it to one of my patients, and I just said, it's okay to think about you.
Yeah.
Because they were in a time when they were worried about all these other things and they were really struggling. And I'm like, it's okay to think about you, and think about what could help you, um, and to give yourself some grace in this. Like it might be harder to go to work for 8 hours. It's not unexpected. And so trying to frame it that way too when some of these things come up.
Yeah. Brilliant. Amelita, what would you change if you could change something?
So for me, I still want to go back into as a provider, like being open as much as possible to your patients, and I'm going to explain that a little bit. So I think the very cause of patients turning into social media, AI for their health questions is because they get a bit frustrated about their providers, like they're not available, or like they answer messages like 5, 7 days, maybe even more, and that's when they run into sources that are, internet and all, like maybe friends or yeah. So my uh advocacy or my advice is as much as possible, be open, have an open communication with them. But I know sometimes it's not possible because we might get bombarded with questions, like we have our own patients now, and then we have to answer questions from them. So I'm gonna teach you a little trick. And this is what I've done as well when I was doing my residency when I was a primary care physician. Have like a regular check-in to your patients, like maybe monthly or maybe every other month. Just ask them a question, like maybe via my card or maybe a quick phone call. Initiate it, like ask them how they're doing and like is there anything I can help you with right now? And chances are they might say like, no, I'm okay, I'm good, I appreciate the call. Because if you don't do that and you wait for them to ask you a question, like for me, like for example, if I haven't heard from my doctor in a while, like I get the chance of like, oh maybe I should like ask them something. But if they end up being the one who's asking me like how I am doing, chances are I'm gonna say, oh, I'm doing well. So it's kind of a contradicting technique, but I think it works wonders. And if, for example, if you ask them and they say something that's a bit concerning, then become aggressive at that point, and we don't have to wait that it turns out it becomes an emergency down the line. So try that and let me know.
Great suggestion as well. And especially it's about kind of that connection and coming back to Marcy, what you said earlier, the relationship piece is such an important part of kind of the thread throughout. Which leads me to sort of my final question for both of you. Imagine there were no constraints, financial, logistics, or otherwise. What would the perfect program look like to help people sort of come through that journey from diagnosis through to survivorship in the best way possible? So, Marcy, I'll start with you.
So I would say that I think our program is kind of close to what I would do. At least it has the components. I would love more of a dedicated space for survivorship that could be a little bit less hustle and bustle of a normal clinic. I would love to have a clinical psychologist or social worker involved. Um, and reimbursement being more of like a bundle. Like if you have head and neck cancer, these are the services you're going to get because we know that they're going to improve your long-term outcomes. So for insurances, that'll help them down the line. Um, but I think it's also important to really have dedicated staff to really follow patients, build those relationships. And I think a lot of structures, people have other jobs to do.
Mhm.
And so I would say having, a designated staff members like a nurse practitioner or it's really hard for physicians, I think, economically to be in that space, but having a dedicated nurse practitioner, a dedicated core, like a navigator, some of those things would really allow those growth. I would even add a researcher in there because I think one of the things we struggle with so you could add a researcher like me, and because we can think about how do you show the value of these programs
Mm.
to the we know, I think we know a lot of times that these programs have value to patients, and patients tell us wonderful stories and tell us they're really satisfied, or this is what they would do different, or they want free parking. I completely understand. But a lot of times we unfortunately then have to justify this to our institution, and we may not make as much money as a surgeon or as a medical oncologist. And so really being able to have somebody take that and look at it in terms of other different cost benefit approaches could really also be helpful. And I think that kind of data is what really will help move policy forward if we can show what types of models help, what types of models improve patient outcomes, or cost benefit ratio, looking at some of those quality of care frameworks and survivorship and just ticking those boxes so we have the strongest amount of evidence we can. Because I do unfortunately think sometimes survivorship care and survivorship research gets looked at a little bit differently than, drug trials and things. It's always been can be called soft science, all of those things. And I just think it can be done rigorously with the patient in mind. It's not soft science, it's survivors' lives. It's there every day. And that is as important to me as anything else.
But I love the fact that you added the research element as well, because I think we all know that, but the more you can
Hmm.
put some quantitative stuff
Hmm.
to back it up, that data is so critical that
Hmm.
yeah, I'm here to support your researcher in every center model.
Hmm. Nurse researchers everywhere we go now.
And Amelito, what would
And
you
that
do?
would, yeah, I would add on to that, like having the benefit of data, of information generated by researchers, um, will help us support, like for example, I'm a researcher myself, so for example, if I'm publishing something that proves this, that oh, this exercise helps more than 50% of survivors, that might make certain foundations or even the NIH become more interested in investing uh, more funding. So I think that's another added benefit to that. But I just want to lean on a little bit on some of the questions I'm seeing in the chat.
Okay,
So,
great. Yeah.
pa palliative care. I definitely agree. I think there's some sort of a misconception about palliative care and its concept. Like people might think that only those who are at the end of life are the ones who need it. But I don't think that's true. Palliative care also manages of acute problems, like for example, pain management, which is definitely a common concern for many cancer patients and survivors. So early referral to palliative care if you think that they will benefit um, if they will benefit from that service or specialty might be really helpful for some population.
Awesome. And thanks. You jumped into, I was going to say, I really wanted to address a few of the things. So Amanda Patch also mentioned the Waltz Fritz manual. Was curious if you guys know about the Waltz Fritz manual therapy training. She mentioned that it was something excellent. And I don't know, Amanda, if you wanted to share a little bit more in the group as well, if you're still here.
I am here. Can you hear me?
Yes.
Great. Sorry, I'm in the car. Yeah, I work, so I'm a speech pathologist. I work a lot with the head and neck cancer population, but recently I started helping the outpatient palliative care team and supporting them outpatient for these chronic head and neck cancer patients. And so trismus is I come across a lot of patients with trismus, long-term trismus. And so even just trying to improve oral opening to so they can eat a burger again is within, something to meet their goals and quality of life. But I took a manual therapy course with Walt Fritz, and it just works on a lot of like manual manipulation of the head and neck area to just help with range of motion. So yes, he does in person, online, and also in person trainings. He's a fantastic educator.
Yeah, I think we're huge advocates for intraoral work. Our physical therapists and our PTs kind of overlap in a little bit because we have at least one that does like lymphedema or manual therapy in our SLP group. Our PTs, we really built off the men's and women's health group. And so it really, because they have a lot of lymphedema certified therapists, so they do a lot of manual therapy. One of the things that I've been lucky to do for patients, we have a lot of people who donate funds. So we buy Therabytes so we can give Therabytes out early for free. We buy dental, especially when you have trismus, your dentist. That's a battle. But a lot of things, high fluoride toothpaste, all of those things. But I completely agree. I think manual therapy in lots of different components can be exceptional. Myofascial release, the Graston kind of technique can be very, very helpful for some of these really late radiation-induced fibrosis syndromes. And that is where most of my research lies. So, hoping to understand why biologically people are very different at times when it comes to fibrosis.
imagine a passion that too. I've been having manual therapy too myself, and I would say it's much more effective than the we call that flexi the computer vest pipe compression, like on the automated one.
Hmm.
Manual is still significantly better.
Yeah. I think that the nice part about the Flexi Touch that I like is, especially if you don't have a manual therapist close, then that gives you an
Yeah.
option to do it. But I would say our patients would agree. Many of them just feel they get more benefit with the manual therapy, and they can never quite do it the same at home.
Mhm. And then I saw we had one more comment from Amy. So we've talked a little bit about sort of incorporating the palliative model, but this is specifically
Mhm.
for you, Marci, in your practice. Anything else you'd expand on for there? I think the other part is more about the business case. You're welcome
Yeah.
to share a little bit more about that. If there was something in particular, sort of words of wisdom you can give other folks who might be looking to explore that.
Yeah, so when I first started survivorship, my colleague is a palliative care provider. She does family meetings in the ICU, and I always said I do survivorship, and she was like, "But you do primary palliative care." She's like, "That's what you do. That's what you are. That's what." And I'm like, "What? I am a cancer survivor, researcher, and clinician." Um, but so I think that that's the way to really it, I think I'm a certified now because of all of those words of wisdom. I'm a certified hospice and palliative care nurse, so I think I bring that primary palliative care approach into survivorship. But I think there's other ways to do it, and we use our palliative care team as needed then too, because I don't prescribe medications and things like that. So for pain and kind of those acute on top of chronic pain. And so that is something that we kind of have referrals built in for. We've had a little bit of turnover, so it's harder, but it's really helping to coordinate them. But I would say that survivorship is really kind of a primary palliative care approach to treating patients, understanding their holistic needs and kind of addressing them. I always feel like we give so many terms like prehabilitation, survivorship, palliative care, and there's so much overlapping and intertwining principles with what we do. The business model. Amy, I can give you my email if you'd like, and you are welcome to email me and we can chat more about it and how we've done it. And I've laid it out now. But I also have some papers coming up that I think will help make the case too. So I don't know, you can all have my email if you want, but I put it in the chat and we can talk a little bit more about it if you'd like. It is difficult. I mean, I think I'm in a surgical department, so I don't, every kind of survivorship lands in a lot of different places. Head and neck surgery was just the place I landed, because they were most open to a new and inventive approach. And so the downside is, survivorship care, I think we can set it up so we do make some money, but I will never make as much money as a head and neck surgeon doing a flap. So I think there's also additional data to track there, which we kind of mentioned. And so you're going to get a multi-tier approach to when you um, do that. But I also would say, how many survivors are we going to have in 2030? 22 million. So
Mhm.
that's a lot of people, 1 in 3. So there's going to be a need, regardless of kind of what our institutions want to talk about. There is going to be a pressing need to be able to really provide high quality care to people. I would say starting early, but in that unique phase of after treatment when you're kind of going back to your life. But you still have the effects. And how can we best do that as patients are living longer? So I like to say, I don't know if my cancer center director is tired of me saying it, but I say that this is um, one of the most significant challenges of modern oncology care. Um, And I say it over and over again. So maybe someday I will convince everyone. But I just think we have a duty, that we really have a duty to our survivors to really continue to push for better care.
I think you'll find a lot of people on the call would agree with you completely when it comes to that assessment.
Reaching to the choir.
Preaching to the choir, but always
Yeah.
good to hear it.
And,
We
and to add,
go ahead. Yes.
so I'll just add on a little bit to that. I think right now with the advent of immunotherapies, there's different types now. So I think we've been very used to the common side effects of chemo, right? Like fatigue or uh, wooziness, chemo brain. But I think in the advent of immunotherapy, there's a lot more different side effects that you should watch out for. And one of them, and this is how I used to remember them, so the different type of itis, different type of inflammation, like myocarditis, sometimes meningitis, or sometimes autoimmune disorders.
Mm.
It could be precipitated by the use of this newer immunotherapy agents. So the trade-off is that survival rates are definitely better, but the trade-off is that there's newer adverse effects that we should be mindful about.
That's such a
Agree.
great point. Thank you for adding that because it's true. This is, I mean, we're kind of uncharted territory, right? Of the first people who are coming into survivorship having benefited from these new innovations and treatment, and it
And we're
presents.
moving them earlier because we're doing it
Yeah.
in neoadjuvant setting before surgery. So that adds another uniqueness to it. So there's a lot of work still to be done.
A lot of work to be done. So we have just about 2 minutes. I wanted to see maybe we have time for maybe one question left. So if there's anyone else from the group who'd like to ask a question of our experts, you can have the floor. Feel free to just come off your mic, or you can type it in the chat as well. Otherwise, if not, we've recorded this session, so we'll make sure to, so everyone who's signed up, you'll get the recording to the session as well as an invitation to our next Expert Insight session, which we'll have in September. And if you have any follow-up questions for either Amelito or Marci, do feel free to reach out to us as well. I'll drop my email here in the chat. And if you'd ever like to learn more
I
about,
love it.
oh, sorry, go ahead.
Yeah, I know, I'm gonna put out my email as well in case.
Perfect.
Yeah.
So feel free to reach out to either of our experts now that you'll have their emails. If you have further questions on the topic, feel free to reach out to me if you have questions about the after cancer, would like to learn more about our model and how we partner and support. Please do so. And otherwise, take care and have a great rest of your day. Thanks so much for joining.